this week and speaker series. Thank you for joining us today. My name is Nee Nguyen. I'm a nurse here in the PACU at Sick Kids, and I'll be the facilitator for today. So today's session will be recorded and available for those who request access. So we appreciate that the timing of our speaker series is not necessarily accessible to all staff, especially those who are currently providing frontline care to patients and families at this time. So we're hoping to record these sessions to improve access to education for all staff and clinicians. We also ask that during the question and answer time at the end of the session, please don't disclose any confidential patient information. This is the first time we're actually doing a speaker series event like this, and we're hoping to reach out to as many Sick Kids staff, trainees, and students, as well as people from outside of Sick Kids. So you'll see on the screen above there that we have one more session for tomorrow from 12 to 1, and we hope that you can join tomorrow. We're also hoping to learn a little bit more about people who are joining us today. If you're comfortable, would you be able to introduce yourself in the chat? Just include your role here or in your organization. You guys can write in the chat if you'd like, but I'm just going to go up to the next slide if that's okay with everyone. So before introducing our speakers and topic today, I would also like to first acknowledge the land in which the Sick Kids operates. So for thousands of years, it's been a traditional land of the Huron-Wendat and Pendon First Nations, the Seneca, and most recently the Mississauga of the Credit Valley of Credit River. Today, Toronto is home to Indigenous people from across the Turtle Island. Sick Kids is committed to working towards new relationships that includes First Nations, Inuit, Métis people, and we're grateful for the opportunity to share this land in caring for children and their families. Awesome. So we have Heather, who is a nurse practitioner, and she's from London Health Sciences. We have Arthur, who's a nurse in the general paediatrics ward here at Sick Kids. So it's my great pleasure to introduce our speakers today, Jacqueline Hanley and Ashley Harvey. Jacqueline has worked as a clinical nurse specialist with the acute pain service since 2015. She co-chairs the Pain Matters Committee here at Sick Kids. In addition to her passion to facilitate best practices, pain practices here, she aims to promote safe opioid practices as part of the Medication Safety Committee. She also regularly develops and delivers pain assessment and management educations for the nurses, the interdisciplinary healthcare professionals, and health discipline students as part of her role. Ashley has been a nurse here at Sick Kids for nearly 13 years. She's also joined the acute pain service as a clinical nurse specialist in 2020. Like Jacqueline, she also has a passion for developing and delivering pain-related education for nurses and other interdisciplinary staff at Sick Kids, as well as the broader healthcare community. As part of her clinical responsibility, Ashley is also the advanced practice nursing lead for the recently implemented ambulatory continuous peripheral nerve block program here at Sick Kids. Today's session that Jacqueline and Ashley are presenting will teach us a little bit more about pharmacological pain management strategies for pediatrics. I thank them for their talk.
Thanks, Nia. I appreciate it. I'm just going to share my screen now. Is that working out, Ashley? No, you've got the presenter. I've got Ashley right next to me so I can peek to see that it's all working. Looks good. Okay. We just want to thank everybody again for joining us today, and thank you, Nee, for the introduction. I'll skip through my own introduction since you covered everything so well. Just want to start off by saying neither Ashley or I have any financial disclosures to make, and we are both paid employees of the Hospital for Sick Children. I'd also like to start this talk by sharing the personal lens that Ashley and I approach this talk with. So the vantage point that this information is presented from is that we're both pediatric nurses. We have always been pediatric nurses as long as we've practiced. We are inpatient nurses, and we've both always worked in inpatient acute care at sick kids, so a high resource acute care setting. And so the experiential knowledge that we share and these sort of clinical pearls of wisdom that come through this talk, they come from the perspective of two people who have always worked in this environment and right now are working on a consulting service within this environment. It's important to us that our audience knows that these are all factors that are going to impact the information that we share. So some of the resources that we have here and the patient populations that we are accustomed to seeing, the methods by which we prescribe and titrate, they may be more geared towards this type of setting as opposed to a pediatric outpatient setting or a low resource setting. So that being said, if you're joining us today with a very different lens or from a different setting, or you have questions or feedback or anything you want to share, we really encourage that when we open things up at the end of the presentation. Today, we're going to be looking at some principles of pharmacological pain management, some common analgesics and adjuvants, and understand when they're indicated. We'll look at some basic opioid titration examples and talk about some first-line medications used in the treatment of neuropathic pain. And before we get into actually looking at the types of medications we use for pharmacological treatment of pediatric pain, I just want to do a very high-level quick overview of how pediatric pain pharmacotherapy might differ from adult pain management or even adolescent pain management in regards to dosing, pharmacokinetics, and sometimes even the choice of agents. It's important to understand that infants have longer gastric emptying time, they have longer transit time, they have differences in the pH of their gastric system, also bile and pancreatic fluid activity, and all of that means that GI absorption of medications might be slower in infants than in older children and adults. Infants also have less blood proteins like albumin, and the drugs bind to these blood proteins. So when there's less of them, that means there's more active unbound drug molecules in the bloodstream. Those proteins reach adult levels around 1 year of age or so. Another difference with infants is that they also have proportionally a larger total body water percentage. So this can mean that sometimes when we're giving medications and trying to titrate up, they might need a larger initial dose of medication to reach a therapeutic effect. Hepatic enzyme maturation also differs, and that impacts drug metabolism. It's within the first year of life or so that we can expect elimination half-life of medications to match adult levels, but until then, those deficiencies can result in increased risk of drug toxicity in infants and young children. And a decreased daily maintenance dose or an increased dosing interval is sometimes needed in order to avoid drug accumulation. Then when it comes to renal excretion, the GFR, glomerular filtration rate, and tubular secretion isn't mature until about 6 to 8 months of age. And so there can be slower elimination of opioids and the metabolites. And then lastly, in terms of actually responding to some of the effects of medications like opioids, infants have an immature ventilatory reflex. So in response to hypoxia and hypercarbia, they may not compensate as well. They may have a higher risk of depressed respiratory drive. So keeping these differences in mind, it is possible that you could still dose and use opioids and non-opioid agents safely and effectively. It's just something that we have to consider when we're looking at the pharmacology of using these meds in young children.
So we do think it's important to cover kind of quickly some basic principles of pharmacological pain management before we actually get into the different types of medications we use to treat pain. So these are principles that we always try to keep top of mind when we're rounding on our patients on the acute pain service. So first and foremost, we always use a multimodal approach, meaning that we combine various modalities and medications to target pain through various pathways. And this can include simple analgesics or non-opioids, opioids, adjuvants, as well as regional modalities. And we know that using a multimodal approach often results in reduced opioid requirements for our patients and thereby their associated side effects, and can result in overall better patient outcomes. And in most situations, we also do prefer to use the least invasive route when we're administering medication. Often it's the most convenient route, and we tend to gear a bit more towards PO or enteral dosing if a patient has an oral route available that we're able to use. However, in some situations, and we recognize this on our service as well, when pain is severe, it is best practice to consider routes that allow for a quicker onset of action, such as intranasal or IV administration. The latter approach refers to stepwise addition of medications as needed for more severe pain. So simple analgesics such as acetaminophen and NSAIDs can be provided for mild pain, plus the addition of adjuvants as appropriate depending on the etiology or mechanism of the pain. And then opioids should be considered and added if appropriate for pain that is more moderate to severe. The step down approach then is similar to our step up approach, whereby as pain is improving and opioids are no longer required, or perhaps only the odd PRN maybe is being used for pain management, it's appropriate to continue scheduled or around the clock simple analgesics, usually for a short duration of time before switching your simple analgesics to PRN. So we step up and we step down in a similar fashion. The next principle is individualized management. And by that, what we mean is not a one size fits all approach doesn't work for all of our patients. So typically we do start with weight-based dosing. And when we're thinking about our opioid naive patients, we tend to start on the more conservative end for our opioid naive patients when we're looking at our weight-based dosing guidelines. And then we titrate those medications to effect. So we want to try to get the best analgesic benefit from our medications with the least amount of side effects while attempting to use sort of the least or lowest effective opioid dose possible. It is important to remember when we're thinking about an individualized management approach that some patients have variable responses to medication. So for example, sometimes one type of NSAID or opioid will work better for one patient than other patients. So it's reasonable and should be part of your practice to consider rotating medications if a trial of one has either not produced adequate analgesia or the side effects have become unmanageable. And lastly, we want to match medication dosing frequency and schedule to the pattern of pain. So when pain is expected or continuous, we want to ensure that the medications to manage the pain are then scheduled or continuous if you're using an IV infusion. PRNs or as needed medications should be available in addition to the scheduled or the continuous medications for episodes of intermittent unmanageable pain episodes. We also use PRNs sometimes alone as standalones in situations where a patient has no pain or minimal pain at baseline, but they may have intermittent episodes of pain that require management, or in situations where a particular activity may cause unmanageable pain. So for example, a PRN could be provided before physio, for example, if we know that the physiotherapy is going to cause a child more pain. Next slide, please, thanks. So starting off with our simple analgesics or our non-opioids, acetaminophen, we all know and love. I will just preface this next section of our presentation to let everyone know that these slides are fairly information heavy. We're really just going to speak to sort of the most relevant points and things that relate to our own clinical experience, but please feel free to take screenshots if these slides are helpful for you and you want to refer back to them at a later time. So acetaminophen is a first-line medication for pain management that can safely be combined with non-steroidal anti-inflammatories for management of pain, ranging from mild to severe. One of the benefits of acetaminophen is it does have many formulations, which makes it very accessible for patients who may not have an enteral route, for example. We are very fortunate here at Sick Kids that we do have access to IV acetaminophen. It is quite expensive, so it really is reserved for patients who are truly NPO, are not able to take anything enterally. And typically that particular order does require a prescriber to review every 24 hours to ensure that the IV formulation is in fact still required. Acetaminophen is a good basic analgesic, but it does lack some peripheral anti-inflammatory properties. So as I mentioned, combining it with a non-steroidal anti-inflammatory may be a good option for patients whose pain may also in part be a result of an inflammatory process. We do have some examples listed on the slide here for pain situations where acetaminophen would be a good analgesic option, and that includes things like headache management, possibly dental pain, MSK pain, just to name a few. On our acute pain service at Sick Kids, I will tell you that our perioperative pain management plans will almost always include scheduled acetaminophen. The route will differ depending on what the procedure is the child is having. The patients where we have to use some caution or speak to a specialist would be those who do have some hepatic impairment. And in those situations, we may have to look at either not including acetaminophen, looking at using a lower dose, or perhaps only using it as PRN. It just depends on the clinical situation. Next slide, please.
Okay, thanks, Ashley. So we're going to talk about NSAIDs next. So NSAIDs are another first-line option for pain control, typically used for mild to moderate pain, although also added on for severe pain when opioids are used. And there's some good evidence that ketorolac specifically has been shown to be just as effective as opioids for treatment of some moderate to severe pain like fractures. The most common NSAIDs we see in use here are ibuprofen, which is an oral formulation, ketorolac, which we usually use as IV, but also has an oral formulation, naproxen, which is also known as Aleve over the counter, and celecoxib or Celebrex. My slide clicking isn't working here. There we go. So NSAIDs work by inhibiting COX-1 and COX-2 enzymes, which are involved in the synthesis of prostaglandins. And prostaglandins are involved in a number of different processes all over the body. So one example would be in the GI mucosa, they're involved in the protection of the mucosa. In the kidney, they increase glomerular filtration rates. They're involved in platelet aggregation and inflammation, and in the fever response. Probably irrelevant, but fun fact, they also increase mating behavior in goldfish. Who knew? So when we look at what prostaglandins do and understand that NSAIDs inhibit the enzymes involved in their production, we can understand the side effect profile of NSAIDs. Because of these side effects, NSAIDs tend to be avoided in patients who have impaired renal function or severe cardiac or hepatic impairment, anyone who's actively bleeding or has coagulopathy, or if they're using a concurrent anticoagulant drug. On our acute pain service, we try to use them as often as possible. They're fantastic for pain associated with things like chest tubes, like pleuritic pain, any type of MSK pain, anywhere, any surgical pain where there's any inflammation. But we are sometimes limited based on the type of surgery or on some clinical characteristics of the patient. Because COX-1 and COX-2 enzymes are expressed in different areas of the body, NSAIDs that differentially target each enzyme have a slightly different side effect profile, and that's kind of shown here on this slide. When it comes to selecting an NSAID, it's important to understand that evidence does show that at therapeutic doses, they tend to be equally efficacious. The major difference in them is their therapeutic half-lives and in their safety profiles based on sort of whether they're COX-2 selective or a non-selective NSAID. Ketorolac specifically, it does have a higher demonstrated potency than most other NSAIDs, but other than that, they sort of all tend to work equally well. That's what the literature says. Ibuprofen or Advil is usually a good first-line option if we're looking to decrease the risk for GI side effects. For example, in someone that might need an NSAID longer term, we might lean towards a COX-2 selective NSAID, so something like celecoxib might be a better option. We don't use aspirin as an analgesic, especially in children, but it is on here just to show a comparison to the other commonly used NSAIDs. And as an irreversibly non-selective NSAID, it's often used to prevent thrombi because of its antiplatelet aggregation effects.
So now that we have covered our simple analgesics, we thought it might be a good time to pause and actually walk through a bit of a case example. So the patient we're presenting here obviously is a fictitious patient. We have named her Simone. I will let you know, though, that this case example is based off of patients who we have followed in the hospital before. So definitely relevant to the types of patient populations we're seeing. So Simone is 16 years old, and she's presenting to your clinic, or you're somehow interacting with her during your practice, and she's coming in with some complaints of pain. She does have bilateral flat feet, which was noticed around age 8. And she's currently on a wait list for surgery. Everyone knows about our surgical backlogs, so they exist. And we're expecting that she's going to have her surgery in about 2 to 3 months, but we're not exactly sure. And typically with bilateral flat feet, the surgery would be unilateral. So she would have one side corrected, and then about a year later would have the other side corrected. She tells you that she started noticing pain in her feet about a year ago, but really it was quite manageable at first. And she says that's about a 2 to 3 out of 10 on the NRS scale. Doesn't interfere with her day-to-day activity. She's able to go to school, hang out with her friends, no problem. But over the past 2 months, what she's found is that her pain's been increasing to maybe 6 to 7 on 10 when she's been on her feet for long periods of time. So this could be like when she's going to the mall with her friends on the weekend, as an example. And when her pain increases after these big days, the pain tends to linger for 24 to 48 hours. So you ask her if she's taken any pain medications, and she responds with, I took some Tylenol and it didn't help, which is probably something we hear at least once a day on our pain service. So what do you want to know and what would you recommend? So we're gonna walk through this, but like also happy for people to kind of like spitball in the chat as well. So really, this is where performing a thorough pain assessment is essential. Your assessment should include, among a lot of things, but definitely needs to include asking about which medications she's tried and how they were taken, which is a big piece that we want to explore. So we want to know what was the dose that she took, if she remembers, how often did she take it? So when she said she tried it, did she just take one dose, or did she actually try it, say for example, every 6 hours for 24 hours? So really, when people say a particular medication didn't work, that's our opportunity to dig a bit deeper and try to get some more information. So let's say that Simone was taking an optimized dose of acetaminophen, but she took a dose maybe only once in the morning and once before bed. What may be helpful for Simone is the addition of a non-steroidal anti-inflammatory, and you could suggest first something over the counter like ibuprofen, because that's a bit more accessible. You could suggest dosing it about every 6 to 8 hours for the duration of the more moderate to severe pain that she's experiencing. And this is safe to be combined with some around the clock or scheduled acetaminophen that can be dosed at the same time if that makes it more convenient for her. I will just quickly say a plug that part of our role as APNs on the acute pain service is doing a lot of education around medication management with patients and families. And it is a common misconception that acetaminophen and NSAIDs cannot be administered together. So we do make a point of educating or counseling our patients and families that they are safe to be administered together. So if it's not something you're currently doing in your practice, it might be something worth adding in. We do sometimes find, we've mentioned this already, but one NSAID sometimes works better than others for some patients. So it could be an option to rotate to another NSAID like Celebrex or naproxen, as Jacqueline was just mentioning, if Simone isn't finding the ibuprofen to be as helpful as we may have hoped. Also, it may be helpful to provide some education to Simone and suggest that she maybe consider taking some preemptive analgesia before these big days. So if she normally struggles after a big day of walking out with her friends, she could consider taking a dose of acetaminophen and an NSAID prior to an outing. And that may help her in the long run with her pain management while she's waiting for her surgery.
Okay, so we're going to move on to opioids now. So opioids, things like morphine, hydromorphone, fentanyl, they're indicated for moderate to severe pain, and they should be used judiciously with appropriate dosing and assessment to avoid adverse effects and careful monitoring. They're really considered to be a co-therapy along with non-opioid analgesics, and we continue to use them, like Ashley talked about with this ladder effect, alongside the non-opioids, so that we can use the lowest effective dose of opioid possible to get the best analgesic effect and to reduce side effects. Opioids, like our other medications, have various formulations, including oral, rectal, IV, intranasal, subcutaneous, depending on which opioid you're looking at. So they're easy to use in a variety of situations. Their mechanism of action is to work on opioid receptors, primarily mu receptors, also kappa and delta receptors in the central nervous system. The mu receptors are primarily responsible for analgesia, and some of the other ones contribute to some side effects that are most commonly known with opioids, like respiratory depression, sedation, nausea, vomiting, pruritus, euphoria, constipation, urinary retention. They're really considered to be an important part of acute severe pain management, but obviously they carry with them some significant potential for harm. So when we're giving opioids in a hospital environment, we really need to make sure there's appropriate monitoring going along with them. And when we're prescribing opioids for a home environment, they really should be prescribed with the appropriate education so that patients and families know how to use them, how to store them, and importantly, how to dispose of them as well. So let's talk a little bit about opioid selection and route. So firstly, you may notice that a common opioid, codeine, is not listed here. So codeine is the opioid that's contained in a combination with acetaminophen, often called in T3s is usually how people hear about it. But codeine is an opioid that is metabolized to morphine via an enzyme that there are a lot of genetic polymorphisms for, and so the patients have varying enzyme activity. Some people don't metabolize the medication at all, and some people hypermetabolize. So there's varying analgesia and then potential harm associated with that. So otherwise, aside from codeine, we've got morphine, hydromorphone, fentanyl, and oxycodone listed up here. And when choosing an opioid, we take into consideration its half-life, its available routes, its safety profile, and its side effect profile. Morphine is typically considered the first line option for severe pain. It has fairly predictable delivery and is the least potent of all of the opioids listed up here. Hydromorphone, there's evidence that doesn't that suggests that it's not necessarily any more clinically effective than morphine, but there may be a clinical preference with some prescribers to use hydromorphone. Anecdotally, I can say that many of our prescribers prefer it in teenage patients, adolescent patients. There is some evidence that hydromorphone has a little bit less histamine release, possibly less nausea, less pruritus compared to morphine, but that is a bit mixed. And hydromorphone is an opioid that may be preferred in renal failure over morphine just because its metabolites are a little bit less, they impact the body a little bit less, accumulate a bit less than with morphine. Fentanyl is a little bit of a different beast. So fentanyl is a lipophilic opioid as opposed to hydromorphone and morphine, which are hydrophilic. Fentanyl has a very rapid onset and a short duration of action. So that makes it really useful for severe pain that's associated with procedures or painful events of short duration. It does carry a higher risk of tolerance with prolonged use due to its short half-life and the fact that it does accumulate in fat tissues. But it's also a medication that might be helpful in cases of decreased cardiovascular function because it does have less hemodynamic changes associated with its use. One of the nice things about fentanyl is that it can be given intranasally, and that allows faster administration than the IV route. And so it's often used in that way, especially in emergency departments, to treat pain that needs to be addressed very quickly. So it's one of the favorites and first lines in pediatric EDs. And then lastly on this list, we have oxycodone. Oxycodone is metabolized into a drug called oxymorphone. It is another drug that may accumulate in patients with renal failure. We only have an oral version of this medication. We do use this occasionally in our acute pain service here at SickKids. There's some evidence of increased likability of oxycodone compared to other opioids, that there might be more of a euphoric effect associated with it, which suggests a higher risk of misuse. But I will say that those studies aren't done in children who are receiving it for acute pain in a monitored setting. And so we really don't know in this setting if there really is a higher risk of misuse associated with it. Before I exit the slide, I do want to draw attention to a few key differences that help with decision-making between the route of opioid that we choose. So we're going to look at the onset and the peak of oral versus IV formulations. We often hear a belief that IV is for severe pain and PO is or enteral dosing is for less severe pain. But the reality is that at equianalgesic doses, they can both be used for moderate to severe pain and have very similar effect on pain management. The real difference is just in that onset, right? So IV doses have a quicker onset, they have a quicker peak, and so they're best used for sudden, severe pain, and enteral dosing takes a little bit longer to kick in, and so we're going to be using it in situations where we don't necessarily need to jump right on top of the pain in the same way that we would with IV. Oral often offers a bit of a gentler side effect profile as well. You don't have as much of that drug hitting your brain all at once, so less likely to get that euphoric effect, also a bit less likely to get nausea, which seems a bit counterintuitive. But we often advise IV breakthroughs or IV doses for patients who, like I said, have really quick onset, sudden pain, severe pain, whereas an oral dose might be really helpful. Like Ashley mentioned before, before physiotherapy, if physio is going to be painful. So let's say you're in an acute care environment and you've determined that your patient has moderate to severe pain that requires opioids. They don't have an enteral route. We're going to be using IV opioids to manage their pain. I just want to do a really quick review of some of the different indications, benefits, and disadvantages of different methods of administering IV opioids. So intermittent boluses are really helpful for sudden severe pain. They're easy to administer. You don't have to keep your patient attached to lines or monitors. So you just need to monitor them while they're getting their IV boluses. So they're really beneficial for those situations. The one downside of an IV bolus is that you really do get a pretty big peak and valley effect with your blood levels. And so if you have continuous pain, they're really not ideal to be giving for that. We tend to use these for intermittent pain when a patient isn't able to use a PCA for themselves. We'll touch on that coming up. And they're really only requiring something infrequently. Contrast this to a continuous infusion. So continuous infusions are great for patients with no enteral route who have continuous or expected pain. They are effective and safe for infants and small children. So it doesn't need to be reserved for people over a certain size or age or weight. The nice thing about continuous infusions as well is they can be titrated easily through the use of boluses. So we add on PRNs on top of these infusions and can continue to dose the patients until they achieve a good analgesic effect. Some of the downsides are that they are then hooked up to a machine and they do require continuous monitoring to ensure safety throughout. And then lastly, another option for IV opioids would be to use a PCA. So for patients who are willing and able to press a button, they're able to understand and report when pain relief is obtained. They might be able to be set up with a patient-controlled analgesic pump where a dose is pre-prescribed for them and they can push a button that gives them that dose whenever they need it. There's safety features like lockouts, and it can be run with or without a continuous infusion in the background. So we've reviewed the types of opioids, routes of administration, and some of the pros and cons of different ways of giving them. So now we're going to be talking through a little bit about what we think about when we are titrating opioids. So firstly, we always think about opioid titration in terms of both the pattern of the pain and in terms of a balancing act between the analgesic effect and the side effects. So first here, we're going to be looking at the pattern. So is there a presence of ongoing continuous pain? That's the kind of pain that we tend to treat with continuous or scheduled medications, as we mentioned before. And then we think about the episodic pain that the patient might be having. That's the kind of pain that we treat with PRNs. So if you have a patient that is reporting a high pain score, let's consider what is the pattern of the pain. If their baseline pain is unmanaged, then usually what we would do is consider a higher background or a higher scheduled dose to manage that continuous level of pain, their baseline pain. But if their baseline pain is manageable, but what they're having are unmanaged intermittent increases, then we're going to be looking at their PRNs. Let's use something that helps address that episodic pain. We don't need to be giving them more all of the time necessarily, but we do need to be addressing those episodes throughout the day. But then how do we know if it's actually safe to continue to increase the opioid dose or the frequency that we're giving an opioid? So you've got this patient with pain, you want to go up on things, but how do we know if that's an appropriate thing to do? That's when we start to look at the side effect profile. We know that opioids have no ceiling effect, but when we now have to start to pay attention to what is the analgesic effect, what are the side effects? If a patient is having pain and no side effects are present, and we've determined that this is a pain that makes sense to treat with opioids, then there's room to titrate opioids upwards. And this could be done by encouraging more PRN use. If pain episodes aren't well controlled, it could also mean increasing the amount that they're receiving continuously, either by infusion or scheduled oral doses. But if side effects are present, that's when we need to be really cautious about increasing the dose. If side effects are mild, we can treat the side effects with pharmacological and non-pharmacological interventions. But if the side effects are not mild, or especially if they're potentially harmful, like sedation, respiratory depression, then we're going to be considering actually reducing our opioid dose and possibly rotating to a different opioid or adding on another adjunct. And we're going to talk a little bit about adjuncts coming up. And the other things we want to consider when we're looking at opioid titration is, are we treating a pain that is opioid responsive? So a lot of times when we're involved with patients, we start by treating a surgical pain or an intense medical pain like a vaso-occlusive crisis or mucositis, for example. But the patients can develop other pains. So when somebody starts to develop abdominal pain due to constipation, we're not going to continue to increase their opioids to address that, because that is not an opioid responsive pain. And in fact, opioids can cause more harm in those situations. Other things to consider when you're looking at the whole pain picture is just what other aspects are impacting the pain situation. Is anxiety, mood disorder possibly causing some pain amplification? And are they engaging in other non-pharmacological strategies as well? So we're going to go through a little bit of a case here quickly before talking a little bit about some adjuncts that we also use in pain management. So this is going to be a situation of a 10-year-old with sickle cell disease presenting with a vaso-occlusive crisis. She reports that she took Advil, ibuprofen at home, and a dose of oral morphine with minimal effect. And she describes her pain as 8 out of 10 to her legs, 6 out of 10 to her back. It's worse with movement, but it's always present, throbbing, aching, sometimes sharp, and it's interfering with her appetite, sleep, and mobility. So first things first, we're going to start to think, do we understand the nature of the pain? We want to understand what we're trying to treat. This is a vaso-occlusive crisis. We pretty much have an idea of what we're treating, but we do want to assess the patient to make sure that there isn't something else going on. For example, is there an element of musculoskeletal pain? When people complain of lower back pain, we do need to rule out muscle spasm or any sort of muscular condition. We want to make sure there's no infection, osteomyelitis, anything going on in the joints as well. We need to understand the pattern of the pain. So going back to that slide, we just talked about going through opioid titration steps. Is the pain continuous? Is the pain fluctuating? And if so, how often is it fluctuating and what brings it on? We want to know what she's tried, what's helped, what didn't help. And we need to understand if she has side effects. So all of these are important to know before we start actually making decisions about her pain management. So here's what we're going to consider. We're going to start off following the opioid or the analgesic ladder with our simple analgesics. So something like Tylenol and an NSAID around the clock, maximizing the dose for her weight. And then when it comes to adding on opioids, which are appropriate to do because it's the right type of pain to treat opioids with, and it's a severe pain that she's experiencing, we need to consider what route is available to us. If she's able to take things enterally, or if we want to go to an IV route, we need to address her continuous pain with continuous medication. And then we also need to allow for PRNs to treat fluctuations in pain and to allow us to titrate upwards if we need to, if the continuous amount we've prescribed is not sufficient. So one example of what we might do for a patient like this is to maximize an acetaminophen dose around the clock, to maximize an NSAID dose around the clock, and to add on an opioid infusion with boluses available. If you then encounter this patient the next day and you're finding that they're using a lot of their PRNs, their pain is still continuously present, rated severe, and they're having a lot of side effects, pruritus, nausea, mild sedation, especially after they get their PRN doses, we're going to start to consider some other options. So this pain, it remains undermanaged, but side effects are now present. So we're going to be reluctant to go up on the opioids because of all those side effects. We have the option of maybe treating the side effects. We could increase her infusion, but that might not be a great idea because we're already seeing some dangerous side effects here. We can reflect on the NSAID that's being used and possibly rotate NSAIDs. Ketorolac might be a great option in this situation. And because we're using an opioid that is causing side effects, we might consider rotating to a different opioid along with a dose reduction in order to see if we get better analgesic effect with less side effect profile. Then we're also going to start to look at the addition of opioid sparing adjuncts. So an example might be ketamine. And I'm going to hand over to Ashley to talk about some of those adjuncts.
Perfect. Yes. So adjuncts are also known as adjuvant medications. And one of the things that's so great about adjuncts is that they can be prescribed on their own to address a particular pain issue if it's appropriate. Or like Jacqueline just mentioned, there are situations where we're able to prescribe them in addition to other pain medications to further optimize pain management. So we do have a list here of some of the adjuncts that are available to us, including antidepressants like tricyclic antidepressants and SNRIs, anticonvulsants such as gabapentinoids, corticosteroids, muscle relaxants, which we do use quite often here, as well as some anesthetics. And so the next number of slides are going to focus on some of the more commonly prescribed adjuncts that we use here at Sick Kids on the acute pain service. So leading off with ketamine, which Jacqueline just mentioned, we do use relatively frequently, especially in our patients with sickle cell disease who do have complex or challenging pain to manage. It is a dissociative anesthetic, but when used at low doses, it can be an excellent standalone analgesic in some situations or as an adjunct when we're attempting to opioid spare or manage more complex pain. And the most common patient populations we do tend to prescribe ketamine for include our postoperative patients who have either had a difficult pain management experience in the past with perhaps a previous surgical encounter, or maybe even in a first encounter with a patient who may be undergoing a very extensive surgical procedure where we're expecting that there will be a high likelihood that large opioid doses will be required. I mentioned already our sickle cell patient population, but we also have a lot of patients we follow who develop mucositis following chemotherapy treatment, where simple analgesics and opioids have maybe already been tried but and titrated, but there's still insufficient analgesia and or a patient may be experiencing unmanageable side effects. We also do use ketamine as a standalone agent, I had mentioned, and the most common patient population we use it for in that situation would be children with severe inflammatory bowel disease, where we are trying to avoid opioids. So we may not even prescribe any opioids in that situation and just provide a low-dose ketamine infusion. And then in some instances where a patient perhaps has cancer pain that's refractory to opioids, we may also add in some ketamine as well. We do find that ketamine tends to be very well tolerated by most of our patients. Side effects tend to be dose dependent, and if they occur, it often comes in the form of patients reporting to us that they're feeling a bit loopy while they're awake, or they maybe are experiencing vivid dreams while they're asleep. And if we decrease the infusion rate or stop the infusion, the side effects will go away, so they're not permanent. Onto muscle relaxants. So the most common type that we prescribe here at Sick Kids are methocarbamol and diazepam. We tend to use these medications most often in patients who have had some form of muscle manipulation during a surgical procedure. So this can include patients with scoliosis who are undergoing posterior spinal fusion, as well as our patients with cerebral palsy who are maybe undergoing a surgical muscle release or lengthening. For post-op pain management, we will ensure that these medications are usually first available on an as-needed basis, but then we will sometimes schedule these medications for patients if we're finding that that's what they require to optimize their pain management, if the predominant issue is muscle stiffness or spasms. The most common side effect we see with both methocarbamol and diazepam is sedation, and there is a synergistic effect with these medications when they're combined with opioids or other benzodiazepines. So close monitoring and very careful medication titration is required to ensure that we're optimizing pain management while minimizing the side effects. Next slide, please. I'm going to preface this next section by saying that, and I'm sure everyone on the call already knows this, that neuropathic pain can be very complex and very challenging to not only diagnose, but also to manage. The next few slides are meant to be a very high-level overview of current Canadian recommendations for first-line pharmacological management strategies. It's also important to note that all pharmacological neuropathic pain management treatments are used off-label in children. There are very limited studies available in pediatrics, so recommendations for peds are typically extracted from adult literature. And we do just like to start off this section by just providing a definition, because neuropathic pain may not be as familiar to everyone who's on the call. So the International Association for the Study of Pain does define neuropathic pain as pain caused by a lesion or disease of the somatosensory nervous system. And our first-line treatment options, there's 3 that are currently recommended, that being gabapentinoids, tricyclic antidepressants or TCAs, and serotonin and norepinephrine reuptake inhibitors or SNRIs. Second-line options include opioid analgesics, but in many situations, opioids do actually move further down the treatment lineup due to concerns about chronic use of opioids. So it really depends on the context of the neuropathic pain in terms of where opioids would fall in the treatment lineup. In some situations, opioids may be sort of used most advantageously in situations where it's very minimal use, but for very specific situations. So an example would be if it's very painful for a child to go through physiotherapy with their neuropathic pain, getting a dose of an opioid preemptively may help them manage that physio. Next is cannabinoids, which may be indicated for management of chronic neuropathic pain, but this is a bit of a controversial topic in pediatric populations because we really don't have any evidence that cannabinoids can have, we have evidence that cannabinoids can have negative impacts on the developing brain. So it's really an option that needs to be weighed carefully in terms of risks and benefits. And then fourth line agents include, but are not limited to, topical lidocaine and methadone, just to name a few. There are some others in the fourth line. Next slide, please.
Ashley, I'm just wondering, in the interest of time, if we should pause there and just see if there's any questions from everybody, because we're at the end mark here.
Absolutely.
I think there was a question from Brendan that says, do you find that certain opioids that patients and families are more hesitant to receive because of the stigma? And if so, if they're indicated, how do you approach these conversations?
You want to take that one, Ash, or me?
Oh, go for it. I'll chime in.
Okay. Thanks for the question, Brendan. We do find that happens quite a lot, especially with oxycodone, because people have heard things in the media. So we always talk to patients and families about what addiction truly means. Actually, first, we usually explore with them what their concerns are about the drug, and really try to get to the root of their concern. If the issue is with something like addiction or tolerance or dependence, we try to define those terms for the patient and the family. And, we tell them that when used short term in the treatment of severe pain and using the least or the lowest dose for the least amount of time possible, that the incidence of addiction is quite rare in pediatric patients, and we assure them that they're going to be monitored. In terms of things like concerns about tolerance or dependence, we assure them that that is a very normal process that happens when someone is on opioids, and that we can wean them off following appropriate protocols. So usually that addresses their concerns, although everyone has slightly different things that they're concerned about. I don't know if you wanted to add anything to that, Ashley. And I think I'm going to stop sharing my slide now. If there's any other questions from the group, the next couple of slides that we had were just sort of digging into details on gabapentinoids and TCAs, but I think that we'll just pause here. Sounds like a quiet group. All right, Ashley, any closing thoughts?
There is a question from Michelle in the chat. I'll read it out. So she asks, does the acute pain service or team at Sick Kids typically start the discussion about adjunct pain modalities pre-operatively to prep the patient family in advance? That's a great question, Michelle. And it depends on the situation. So we have situations where patients who have had more complex pain in the past or complex procedures in the past are fortunately able to see our colleagues in the transitional pain service pre-operatively to either optimize pain management before coming in for surgery and to receive some counseling in terms of what their pain management may look like post-operatively. So certainly in those situations, our colleagues in the transitional pain service are able to provide that education to families. We do have lots of patients that we get involved with post-operatively where if we're adding an adjunct, for example, like ketamine, and we're already following a patient or we're consulted specifically to consider ketamine, we always provide education to families before just ordering it. But in some situations where we don't always know what the pain's going to be like after surgery. So sometimes it's sort of an after the fact that we're then considering adding in an adjunct to help with their pain management afterwards. So I'm not sure if there's anything else you wanted to add, Jacqueline. Yeah. We do as much, I mean, with adjuncts, we always do try to provide education to families before adding them in. It's just whether or not we have that opportunity to do counseling pre-op. It's just a context dependent situation. And then Brendan's asked, for the kids on infusions of opioids, how long are they on them? And when would you start to think about weaning the infusion slowly, and how slow? Do you want to take that one, Jacqueline?
Sure. So we actually have a really great clinical practice guideline for opioid weaning and withdrawal and benzodiazepine weaning and withdrawal here at Sick Kids. And the algorithm that we follow splits patients into two groups of high risk and low risk. And a couple of things that make somebody high risk of withdrawal would be younger age, multiple agents, or a longer time on opioids or benzos. And then there's the lower risk group. The higher risk group, we tend to recommend weaning by no more than 10% of the original dose per day, monitoring withdrawal scores the entire time. And if we're seeing signs or symptoms of withdrawal, we would return to the last tolerated dose and then slow down the wean and consider the addition of adjuncts to help with weaning, like clonidine. And then for the lower risk group, the recommendation is to wean by about 20% per day. I have seen patients that need to be weaned after 3 days on opioids. I've also seen patients who have been on opioids continuously for over 2 weeks and then stop cold turkey and have absolutely no withdrawal symptoms. But generally, we would say somebody who has been on for about 5 to 7 days continuously is when we would start to consider having to wean them. And then the percentage based on their risk group. And I think Ashley has shared a link to that clinical practice guideline in the chat. It's available on Childkind International's website for those who are external to our organization.
This will just take you to the search page, but if you search withdrawal, then there will be clinical practice guidelines on how to wean patients from opioids and benzodiazepines.
So thanks everyone for coming. I hate to cut us off here just in case there are more questions. Ashley and I have to run to another talk now. But if you guys have any other questions you want to reach out to us, we're always happy to take questions offline. Our email addresses are firstname.lastname@sickkids.ca. So we're always happy to take any comments or questions, and we really appreciate everyone showing up today. Thank you so much.
Thanks everyone. Take care.